Welcome back to the deep dive. Today, we're tackling a really fundamental topic in clinical care, malnutrition.
Hmm.
And, when the sources discuss malnutrition, they're very clear. This isn't just about, well, not getting enough food.
No, definitely not.
It's presented as a whole spectrum.
Yeah,
It covers any deficiency, yes, but also any excess or even just an imbalance in someone's energy and nutrient intake.
that's exactly right. And that's why this deep dive naturally splits into two main areas. We're looking at both ends of that spectrum.
Right.
We've got undernutrition on one side and then obesity on the other. And for you listening, the two sort of priority concepts that really anchor everything are nutrition itself, obviously, and then its really close partner, especially in safety terms, fluid and electrolyte balance.
Okay, so our mission today is really to cut through all the detail and pull out the absolute essentials.
Yeah, the need-to-know stuff.
Things like mandatory assessment standards, the kind of tricky pathophysiology bits, and those critical nursing interventions that are key for patient safety, whether that's managing complex tube feeds or, post-bariatric surgery care.
Let's get into it.
So, starting right at the beginning, assessment. We know the basics for health promotion involve standards like the dietary reference intakes, the DRIs, and those visual aids like MyPlate.
Sure, the standard guidance.
But we also know that what's on the chart in the patient's room, that doesn't really give the full picture, does it?
Not at all. Nutritional status is, well, it's woven from so many other threads, right? Things like cultural food habits, financial realities, spiritual practices, even the patient's individual metabolism or drug interactions.
So much complexity.
Exactly. And that complexity is precisely why that initial screening has to happen fast.
Okay, 24 hours. That sounds really quick, especially when you think about how hectic hospital admissions can be. Are the sources clear on why that specific time frame for the initial nutrition screening is so rigid?
They are quite clear. It's a Joint Commission patient care standard. It must be done within 24 hours of admission. And the why is straightforward. Finding high-risk patients early can prevent really severe, sometimes irreversible, problems down the line.
Makes sense.
The screening questions are targeted, looking quickly for things like unexplained weight loss, ongoing GI problems like malabsorption or other chronic conditions that just dramatically change nutritional needs.
And once that screening flags someone as being at risk, then we move into the more hands-on measurements, the anthropometrics.
That's right. And accuracy here is key. We generally assume patients might, overestimate height and underestimate weight.
Common issue.
Right. So we need precise measurements.
Mm.
And the sources specifically call out unintentional weight loss of 5% in just 1 month or 10% over 6 months.
Okay.
If you see that, it should definitely raise a red flag.
And that leads us to probably the most common metric, body mass index, BMI.
Yes, the workhorse metric. It gives us a quick, although indirect, estimate of total body fat relative to height. Clinically, we define the ranges. Below 18.5 is underweight, 25.0 up to 29.9 is overweight, and then 30.0 and above is obese, which gets broken down further into class 1, 2, or 3.
But it has its limits, right?
Absolutely.
Yeah.
BMI isn't the be-all and end-all. It's known to misclassify people with a lot of muscle mass, like athletes.
Right. Counts muscle as fat, essentially.
Exactly. Or it might actually underestimate the risk in older adults who've lost muscle mass but still carry significant fat.
No, I noticed the sources really emphasize getting a daily weight. They label it the most reliable indicator of fluid status. Why is something seemingly simple like weight more reliable than maybe more complex tests when we're monitoring fluid balance, especially in conditions like heart failure?
That's a critical point, and it links back perfectly to those two priority concepts, nutrition and fluid electrolyte balance.
Yeah.
Getting that daily weight same time, same scale, ideally before breakfast, is flagged as a nursing safety priority.
Yeah.
Why? Because a sudden change in weight is the most immediate and objective sign of fluid gain or loss.
So not necessarily fat gain.
Exactly. If a patient is suddenly 5 pounds heavier overnight, that's almost certainly fluid retention. It's a direct signal of potential heart or kidney problems.
Yeah.
It's much faster than waiting for lab results sometimes.
Got it. We should also quickly mention body surface area, BSA.
Yes, BSA.
It's not just academic, it's calculated using the most stellar formula, and it's absolutely critical for dosing certain high-risk drugs, right, like chemotherapy agents.
Precisely. For drugs with a narrow therapeutic index, getting the dose right is paramount. Being even slightly off can lead to serious toxicity or lack of efficacy. BSA gives a much more individualized measure for calculating those doses compared to just weight alone. Okay, let's shift now to the other side of the coin, the deficiency side. We're talking about protein energy undernutrition, or PEU. Used to be called protein calorie malnutrition, PCM.
Right.
And the sources break PEU down into three really distinct clinical pictures. It's important to tell them apart.
Okay, yeah, this seems like an area where the nuances are easy to overlook. Let's maybe slow down a bit here.
Good idea. First, you have marasmus. Think of this as essentially calorie starvation. The body is literally consuming its own fat stores and muscle tissue for energy.
So the patient looks visibly wasted.
Exactly, emaciated. But, and this is a key differentiator, their serum protein levels, like albumin, might actually be preserved, at least initially.
Interesting. Okay, so that's marasmus. What's next?
Next is kwashiorkor. This is different. It's primarily a lack of protein, specifically high-quality protein, even if the person is getting enough total calories.
So they might not look as thin.
Correct. Their body weight might seem more normal because they haven't wasted as much muscle. But the critical finding is low serum proteins. If albumin is low, that's a big clue for kwashiorkor. It signals poor protein quality or quantity in the diet.
Okay, marasmus is calorie deficit, kwashiorkor is protein deficit, and the third.
The third is simply starvation, which is, well, a complete lack of all nutrients, calories, protein, everything.
The sources really highlight certain high-risk groups, particularly older adults. It seems like there's a strong social component here, too.
Oh, absolutely. The risk factors are a real mix. It's not just the physical things we might think of first, like, poor teeth making it hard to chew, or failing eyesight making cooking difficult. It's often the interaction of that physical decline with psychosocial issues. Things like depression, social isolation, loneliness. Maybe they can't get transportation to the store. These factors can completely wipe out a person's desire or even ability to get and prepare food.
So they just stop eating.
Essentially, yes. Or they rely on convenience foods that lack real nutrition. It's a complex web.
So when we move into managing undernutrition, the ideal goal is always getting them back to eating normally.
Right. Always. Oral intake is preferred. It's the safest, it's the easiest, and usually the cheapest route. Interventions can be pretty straightforward, but effective things like offering 6 smaller meals packed with calories and nutrients rather than 3 large ones.
And supplements.
Yes, providing medical nutrition supplements like Ensure or Boost can make a big difference in bumping up intake.
But what if oral intake just isn't enough or isn't possible? That's when we move to total enteral nutrition, or 10.
Exactly. 10 comes in when the gut itself is working, but the patient simply can't swallow or take in enough food by mouth. This involves feeding tubes.
Short-term versus long-term.
Right. Short-term options are usually nasogastric and NG tube, or sometimes nasoduodenal and NDT. For longer-term feeding, we look at surgically placed tubes like a gastronostomy, G-tube, or a jejunostomy, J-tube, often placed endoscopically, a PEG or PJ.
And how is the feeding actually delivered through these tubes?
There are a few ways. You have bolus feeding, which is like giving larger amounts intermittently, maybe every 4 hours, mimicking meals. Then there's continuous feeding, which is a slow, steady infusion over many hours, kind of like an IV drip.
A more constant.
Yes. And finally, cyclic feeding. This is continuous feeding, but only for a set period, maybe 12 or 18 hours, often overnight, which leaves the patient free from the pump during the day for, say, physical therapy or other activities.
Now, safety with 10 is huge. These aren't simple procedures. What's the absolute #1 critical action when any feeding tube is first placed?
This is non-negotiable. Initial tube placement must be confirmed by an X-ray study, period.
Not by listening for air or checking pH.
Those methods are unreliable and no longer the standard for initial confirmation. You need that radiographic proof before any feeding starts. That's a major safety point.
Okay, X-ray first. What else for safety?
Aspiration prevention is paramount. Keep the head of the bed elevated at least 30 degrees, preferably 45, during the feeding, and for at least an hour afterwards. This uses gravity to help prevent stomach contents from coming back up.
Makes sense. And keeping the tube from clogging. Tube patency. I saw some interesting notes on what not to do.
Yes. Regular flushing is key, usually with 30 milliliters of water every 4 hours during continuous feeds, and always before and after giving medications through the tube.
Okay.
But here's the critical what not to do. Never try to unclog a tube with things like carbonated sodas or cranberry juice.
Why not? Seems like it might work.
The acidity in those drinks can actually cause the protein in the feeding formula to curdle or precipitate, potentially making the clog even worse, like cement. Stick to water for flushing.
Good tip. Okay, this next part seems really crucial, almost counterintuitive. When we finally start feeding someone who's been severely malnourished or starved, There's a big risk, right? Refeeding
Yeah,
syndrome.
this is incredibly important and potentially lethal. Refeeding syndrome is a dangerous metabolic shift that happens when nutrition is reintroduced too quickly after a period of starvation.
What actually happens in the body?
The body, starved for energy, suddenly gets an influx of glucose. To metabolize this glucose, cells desperately pull phosphate, potassium, and magnesium from the bloodstream.
Ah, causing levels to plummet.
Exactly. This rapid electrolyte depletion can lead to severe complications: heart failure, respiratory failure, seizures. The key lab values you must watch for are severe hypophosphatemia, low phosphate, and hypokalemia, low potassium.
So, recognizing those signs early is critical.
Absolutely critical. It requires immediate notification of the provider and careful management of electrolyte replacement and feeding advancement.
And then what if the GI tract just can't be used at all? Maybe due to major surgery, obstruction, or severe malabsorption issues?
In that case, we have to bypass the gut entirely. That's where total parenteral nutrition, or TPN, comes in. This is a highly concentrated hypertonic solution containing glucose, amino acids, lipids, electrolytes, vitamins, everything the body needs delivered directly into the bloodstream via a central venous catheter.
Central line only because it's so concentrated.
Yes, it's too hyperosmolar for peripheral veins. It would damage them. Managing TPN requires very careful monitoring. The infusion rate has to be controlled precisely, usually with a pump. You can't just stop it abruptly,
Why not?
because TPN solutions are incredibly high in glucose. If you suddenly cut off that glucose supply, the patient's pancreas is still pumping out insulin in response, leading to a rapid, severe drop in blood sugar iatrogenic hypoglycemia.
So what do you do if, say, the next bag of TPN isn't ready from the pharmacy?
That's a critical safety point. You must hang a bag of 10% or even 20% dextrose in water, D10W or D20W, at the same infusion rate immediately. This provides enough glucose to prevent that hypoglycemic crash until the TPN is available.
Got it. D10W or D20W is a bridge. And TPN carries other risks, too.
Oh yes, because you're delivering everything intravenously, bypassing the gut's regulatory mechanisms. Patients on TPN are at high risk for fluid overload and significant electrolyte imbalances, things like hyperkalemia, hyponatremia, hypercalcemia. Constant monitoring of labs and fluid status is essential.
Okay, let's pivot now completely to the other end of the spectrum. Obesity, defined, as you said, by a BMI of 30 or higher. The sources talk about a complex mix of causes, right? Environment, behavior, genetics.
Definitely complex. And the genetics piece is interesting. It can range from rare single gene mutations, monogenic, or specific syndromes, to the much more common scenario, which is polygenic, meaning lots of different genes interacting with environmental and behavioral factors to increase susceptibility.
When we're assessing the actual health risk associated with obesity, the sources seem to really push us beyond just looking at the BMI number itself.
That's right. BMI gives us a starting point, but it doesn't tell the whole story about risk. The bigger focus, from a cardiovascular and metabolic standpoint, is on central obesity. Where the fat is located matters a lot.
Meaning fat around the abdomen.
Exactly. Fat accumulation around the waistline and upper body, the apple shape, is a much stronger independent risk factor for things like coronary artery disease and type 2 diabetes than fat stored mostly in the hips and thighs, the pear shape.
So how do we measure that central obesity specifically?
We use two key measurements. First, simple waist circumference. The thresholds for concern are generally greater than 35 inches for women and greater than 40 inches for men. Second is the waist-to-hip ratio, or WHR. You measure the waist at the narrowest point and the hips at the widest point and calculate the ratio. A ratio of 0.8 or higher in women or 0.95 or higher in men indicates that riskier central fat distribution.
Now, when it comes to non-surgical management, the goals might surprise some people. We're not always aiming for a dramatic transformation to an ideal weight, are we?
No, not necessarily. The evidence shows that even a relatively modest weight loss, just 5% to 10% of initial body weight, can lead to really significant improvements in health outcomes.
Like what specifically?
Big improvements in blood sugar control for diabetics or pre-diabetics, lower cholesterol levels, better blood pressure. That 5–10% goal is often much more achievable and sustainable, and it still yields major health benefits.
And a strategy to get there.
It's usually a combination approach. A nutritionally balanced, calorie-controlled diet, often in the range of 1,200 to 1,800 calories per day, depending on the individual, coupled with regular, consistent physical activity. Even something like a brisk 20-minute walk most days can make a difference.
But sometimes non-surgical methods aren't enough, or the obesity is severe. That's when bariatric surgery becomes an option.
Yes. The general criteria are a BMI of 40 or greater, or a BMI of 35 or greater if the patient also has significant obesity-related health problems like severe diabetes, sleep apnea, or heart disease.
And there are different types of surgery?
Broadly, yes. Some procedures primarily restrict the stomach size, like the vertical sleeve gastrectomy or gastric banding. Others combine restriction with malabsorption, meaning they also alter the digestive tract so fewer calories are absorbed.
And the most common one?
The most common combined procedure, often considered the gold standard, is the Roux-en-Y gastric bypass, or RNYGB. It involves creating a small stomach pouch and rerouting the small intestine.
Before surgery, there's quite a bit of preparation involved, isn't there?
Oh, yes. A very thorough psychological evaluation is essential to ensure the patient understands the lifelong changes required and is prepared for them. And often, surgeons require patients to lose some weight before the operation.
Why is that?
It helps reduce the size of the liver and decreases intra-abdominal fat, which actually makes the surgery technically easier and safer. It also helps lower the immediate post-operative risks, especially related to breathing problems or blood clots.
Okay, so post-op care for these patients is critical. They're considered high risk. What's the absolute top nursing priority immediately after bariatric surgery?
Airway management, without a doubt. These patients often have compromised airways to begin with, short, thick necks, potential sleep apnea. Anesthesia and post-op pain medication can further depress breathing.
So positioning is key.
Absolutely. Keeping them in a semi-Fowler's position helps maximize lung expansion. Close monitoring of respiratory rate and oxygen saturation is vital.
There's also a very specific warning about NG tubes if one is placed during surgery.
Yes, this is an action alert in the source material. If an NG tube is inserted, particularly after an open RNYGB procedure, the nurse must never reposition the tube.
Never. Why not?
Because manipulating the tube could inadvertently disrupt the fragile suture line where the stomach pouch connects to the anastomosis. That could cause a leak or bleeding, which is catastrophic. If it seems blocked or out of place, you notify the surgeon immediately. You don't touch it.
And that potential leak, the anastomotic leak, that's the big feared complication.
It is. It's the most common serious complication after gastric bypass and the leading cause of death related to the surgery. Early recognition is key.
What are the signs nurses need to be watching for, like a hawk?
There's a classic triad, often subtle at first. 1, increasing back, shoulder, or abdominal pain that seems out of proportion or just doesn't feel right. 2, unexplained tachycardia, a heart rate that stays elevated without a clear reason, like fever or pain medication wearing off. And 3, oliguria, a significant drop in urine output.
So pain, tachycardia, low urine output, see those, call the surgeon.
Immediately. Don't wait. It's a potential surgical emergency.
Okay. And one more common issue after bypass surgery, dumping syndrome.
Yes. Dumping syndrome. Not usually life-threatening like a leak, but definitely unpleasant for the patient. It happens when food, especially sugary or high-fat food, moves too quickly from the small stomach pouch into the small intestine.
What does it feel like for the patient?
It typically hits within about 30 minutes of eating. Symptoms can include feeling dizzy or faint, vertigo, syncope, a racing heart, tachycardia, sweating, nausea, and sometimes diarrhea.
So patient teaching is crucial here.
Absolutely.
Yeah.
Patients need to learn to avoid foods high in sugar and fat, eat very small meals, eat slowly, and importantly, avoid drinking liquids with their meals. Sipping fluid slowly between meals helps prevent that rapid emptying.
So wrapping this up, it's clear that managing malnutrition across its whole spectrum requires a really deep and broad knowledge base. It goes way beyond just thinking about food trace. You need to understand those subtle diagnostic differences, like between marasmus and kwashiorkor. You need to be ready to manage acute life-threatening crises like refeeding syndrome.
Yeah.
And you have to be vigilant for potentially disastrous surgical complications, like that anastomotic leak after bypass.
It really does tie back perfectly to those initial priority concepts we mentioned. Whether you're dealing with undernutrition or the aftermath of obesity surgery, the patient's fluid and electrolyte balance is almost always precarious, constantly under threat from these rapid metabolic changes or fluid shifts.
Right.
And, having discussed these really powerful life-sustaining interventions, TEN and TPN, artificial nutrition, it naturally leads to a significant ethical consideration.
How so?
Well, think about situations where a patient can't make decisions for themselves and doesn't have clear advance directives. The decision about whether to start or maybe even continue artificial nutrition like tube feeding or TPN becomes incredibly complex.
Yeah, that's tough territory.
It really is. It often requires careful deliberation involving ethics committees, family, the designated power of attorney if there is one, the whole healthcare team.
Yeah.
Just trying to navigate that line between providing support and honoring what might have been the patient's wishes or what's truly in their best interest, a really challenging aspect of care.
It's a powerful reminder that the practice of nursing involves so much more than just following protocols. There's a deep human and ethical dimension to everything we do. Thanks for digging into this with us today.
My pleasure.